This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken only with prior written consent of the AARC. Copyright 2012, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services. I welcome you to today's webcast on ventilator graphics made easy. Upon completion of this AARC webcast, participants will be able to identify and differentiate among specific ventilator-generated graphics. By using ventilator graphics, identify patient asynchrony. After evaluating generated waveforms, detect physiological effects and complications of mechanical ventilation, and improve accuracy when analyzing ventilator-generated graphics. I am pleased to introduce Felix Khusid. Felix is an AARC fellow and a registered respiratory therapist. He holds neonatal pediatric specialist and registered pulmonary function technologist credentials. He is the administrative director of respiratory therapy at Department and Pulmonary Physiology Center at New York Methodist Hospital in Brooklyn, New York. Felix is also an adjunct clinical instructor at the Borough of Manhattan Community College and Long Island University respiratory therapy programs. Mr. Khusid discloses that he has no conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Felix, welcome to the program.
Thank you very much, Bill. I would like to thank AARC for inviting me to conduct this webcast today, and I'm looking forward to conducting this presentation. Good understanding of ventilator graphics is essential in properly managing patients in mechanical ventilation. Typically, the interpretation of graphics for respiratory therapies should be as an interpretation of EKG for a cardiologist. So I really believe that knowing and understanding ventilator graphics will enhance the ability of respiratory therapists to manage their patients better. We're going to go to the first slide, and the first slide, I just want to make sure we can get to the first slide. Okay, hold on a second, sorry. Before we get to the first slide, the most frequently displayed waveforms, as we know, is pressure versus time, flow versus time, and volume versus time. When we're looking at the ventilator graphics, typically the pressure, flow, and volume are displayed in the waveforms. The pressure waveform gives us a lot of information as far as patient triggering is concerned, asynchrony, whether it's a pressure-targeted or volume-targeted type of the breath. We can see the peak inspiratory pressures. We can see plateau pressures when we're performing a maneuver to measure them. We can see the what is the measured inspiratory resistance and compliance on your pressure waveform. You can as well analyze the PEEP levels or CPOP levels that are visible on pressure waveform. In addition, if the patient is actively exhaling, it can be visible on the pressure waveform, as well as airway obstruction, etc. As far as the flow waveform is concerned, when one looks at the flow waveform, it can be very helpful in identifying the bronchodilator response, airway obstruction, if the patient has auto-PEEP, asynchrony. It also helps with analyzing inspiratory and expiratory flow patterns that the patient exhibits, as well as identifying whether it's a volume or pressure-targeted breath, patient triggering, etc. So those are pretty basic, pretty general things that the waveforms can help with. When you're looking at the volume waveform can have some useful information as far as the leaks are concerned. Obviously, the volume that the patient was being delivered to, active exhalation, asynchrony, presence of OTP, air trapping, particularly in COPD patients, etc. So on the first slide, when we look at the first slide, one of the ways of identifying whether the patient is assisting or triggering a ventilator is by looking at the pressure waveform and see if there is any negative deflection on the pressure waveform. Because if there is presence of any negative deflection on the pressure waveform, it's an indication that patient has a spontaneous effort that he or she exhibited triggering a ventilator. On this particular slide, when we look at the pressure waveform, we can see that there is no negative deflection. There is no negative deflection on the pressure waveform, and therefore it's a machine-delivered breath. Now, I would like to also mention that regardless of what mode of ventilation we are in, whether it's a pressure-targeted or volume-targeted or PRVC, most waveforms really reveal themselves in the very same way. If there is a leak, if there is OTP, if there is presence of patient triggering the ventilator, those things typically appear in the pretty much same way, regardless whether it's a volume-targeted strategy or pressure-targeted strategy. So now we're going to go to the second slide, and also we're going to take a look at the pressure control, assist control. This is just a slide coming from a different ventilator, but it doesn't matter what ventilator we are using. Ventilator graphics are pretty generic in nature, and they will reveal the same information regardless of the brand and the make of the ventilator, as long as you have capability of displaying waveforms. So if you look at this particular slide, the same thing. We see that there is no negative deflection on a pressure waveform. And if you look at the, we have flow volume loop on the bottom, and if you look at the flow volume loop, you'll see that there is no patient effort as well. Nothing is getting under the baseline where there is no patient effort conducted. So it's a ventilator-fired breath. Okay. Now, if you're going to go to yet another slide, coming again from another ventilator, we can take a look, and again, we look at the pressure waveform, and on the pressure waveform there is no negative deflection. Therefore, it's a machine-fired breath. Now, when the patient assists, you can take a look at the next slide, and you're going to see that on the pressure waveform, there is a negative deflection. This negative deflection indicates patient effort. If you look at the flow volume loop on the bottom, you can see at the tip of the arrow there is a negative, there is an effort generated by the patient in the form of the very small little loop near letter A, and that's how, if you look at flow volume loops, the inspiratory effort looks like if you look at the loops. But if you look at the waveforms, you can see on the pressure waveform this negative deflection. So anytime you see this negative deflection, you know that it's a spontaneous breath, that patient is assisting. Now we're going to advance to the next slide, and we're going to go to the next slide. Next slide, again, coming from different ventilator, makes really no difference. If you're looking at the pressure waveform, we see no patient effort on the right side, and if you look at the bigger circle on the left side, you're going to see that that circle encompasses negative deflection on the pressure waveform, and that indicates that the patient is triggering a ventilator. So if you look at this slide, what you really have is you have some breath that are patient initiated and some breath that are patient delivered. That machine delivers. I'm sorry. Some are just scheduled breath that the machine has to deliver, and some are assisted breath. We're going to go now to the next slide, and if you look at this slide, this is a slide with the SIMD without pressure support. So in this particular slide, the pressure support is not present, and during this continuous breath, it's unassisted breath. So whatever patient can pull in without the assistance from a ventilator is whatever the patient can pull in. And we can see those efforts that are unfortunately not rewarded by a good return of volume. On the left side, we have an SIMD breath that's a machine-fired breath. Okay? If you're going to go to the next slide, we will see SIMD with pressure support, which is very, very clearly identified. On the left side, we have SIMD breath. That is a machine. Basically, we see that it's a machine-fired breath. There is no negative deflection to the left side of the SIMD breath. And when you look between two SIMD breaths, we have two very clearly marked pressure support assisted breaths that are patient triggered. Because if we look at those pressure supported breaths, we can see that each one of them has nice negative deflection on the pressure waveform. We're going to go to the next slide. And the next slide is going to have CPAP with pressure support. This is, on this slide, we can look at pressure waveform, and we see a negative deflection. We can see a negative deflection on pressure waveform, and then if you're going to go and look at pressure versus, volume versus pressure, we can see that little mini loop that indicates that the patient is initiating a breath. So whether you're looking at waveforms or loops, you get a pretty good idea whether it's a flow versus volume or whether it's a pressure versus flow. You can see that the patient is going behind the baseline and is initiating a new breath. Now, it's also important to notice when you look at loops, this continuous breath typically normally goes clockwise, and the direction of the breath going clockwise, and when we're looking at pressure versus volume, it's counterclockwise, the direction of the breath. And then, of course, flow versus volume is also clockwise. Now, what's also very important to point at this particular slide is that even when you're breathing with CPAP, CPAP with pressure support, you can still manage to have substantial amount of autopy, which we're going to discuss further. But just because someone is in a spontaneous mode does not mean that patient cannot develop significant amount of autopy. It will be very much dependent on the level of pressure support that the patient is getting, and if the patient is receiving the amount of pressure support that results in the larger volume that they can exhale, particularly in your end-stage COPD patients, that can result in a very significant level of autopy. So now we're going to go to the next slide. And again, this is a slide of CPAP with pressure support. One of the good indicators on this particular slide that patient is triggering the ventilator is, of course, this negative deflection in the pressure waveform. And if you look at the second arrow on the right side, the distance between the baseline of the breath and the beginning of the graphic is really the amount of CPAP that the patient is on, or if the patient would be on PEEP, that's the amount of the PEEP or CPAP that one is receiving, which is the baseline, the distance between the baseline and the baseline, I should say baseline of the graphics and the baseline on the pressure waveform. We're going to go now to the next slide. And on this particular slide, I really wanted to talk a little bit about autopy and how it's reflected on when we're looking at the waveform. If you look at this slide, and you look at the flow waveform, you see that on the flow waveform, the breath is not coming back to the baseline. And The reason that the breath is not coming back to the baseline is because patient is not able to empty the lungs from the gas that was delivered to the patient. So if the patient cannot exhale fully, you're going to get intrinsic PEEP built up. There are 3 different types of auto-PEEP, as you all know. You can potentially have dynamic hyperinflation with flow limitations. You can have dynamic hyperinflation without any expiratory flow limitation. Or you can have excessive expiration without dynamic hyperinflation of the lung, which can be caused by dynamic airway collapse. So what's important is when you're looking at the graphics, particularly when you're looking at the flow waveform, you want to make sure that the waveform comes back to the baseline. If the expiratory waveform on a flow waveform does not come back to the baseline, it indicates that there is a trapped gas or an auto-PEEP. You want to make sure that you achieve a status of no flow, where the gas is exhaled and the next breath begins whenever it's scheduled to begin. So if you're going to go to the next slide, I think it's going to be a little more clear on the next slide. If you're going to go to the next slide, you see that when the breath is beginning under the baseline, if you look at the flow waveform, the breath is starting under the baseline. And what it means is that there is trapped gas in the lungs that is not evacuated fully. What's very important as far as the auto-PEEP is concerned is to recognize that the auto-PEEP can cause a lot of hemodynamic instability if not recognized appropriately. Auto-PEEP can cause increase in the thoracic pressure, which will decrease preload of the right and left ventricle. It can increase pulmonary vascular resistance and resulting in hemodynamic instability. So the recognition of auto-PEEP is very important. On the other side, when the patient is breathing spontaneously, auto-PEEP is not recognized by a respirator as its own entity, as regular PEEP. So in order for the patient to trigger a ventilator, they need to overcome the threshold of the PEEP set on a ventilator plus the amount of auto-PEEP sitting as a buffer between the patient and a ventilator. Now, in order to open up the demand valve, so if your auto-PEEP is 10 centimeters, you potentially might have to go to pull 1 centimeter on a ventilator plus 10 centimeters on the of the auto-PEEP that you need to overcome. So now instead of just triggering 1 centimeter of water pressure to open up the demand valve, you might need to go 10 centimeters of water pressure in order to open up the demand valve. If the patient is allowed to work hard with auto-PEEP in order to open up the demand valve every time they want to breathe, it can result in a lot of anaerobic metabolism, causing lactic acidosis and ultimately causing some serious patient-related issues, patient-related issues as they related to being on a ventilator. If you're going to go to the next slide, we're going to see auto-PEEP in PRVC. It doesn't really matter whether it's in PRVC or in its volume-targeted ventilation, pure volume-targeted ventilation or pressure control. Auto-PEEP reveals itself in a pretty much same way regardless of the mode of the ventilation. So again, if you look at the slide, you're going to see the patient is in PRVC and they're initiating a breath under the baseline, where there is no state of no flow. The flow is still going because the patient is initiating the next breath. Now, I wanted to talk a little bit about air leaks. Air leaks can as well cause autocycling of a ventilator. It can cause autocycling of the ventilator as a result of fluctuation in pressures and flows. Air leak can be, if you look at the loops, it's very clear on the loops that air leak is present if the expiratory curve on the pressure volume loop does not return to zero level, or if the expiratory flow curve on the flow volume loop does not return to the zero volume level. So it's very clear on the right side you have a leak. If you look on the right side of the slide, you see a leak, and then if you look at the left side on the slide, if you look at the slide on the left side of the slide, you will see that the flow is coming back to the baseline and there is no leak. Now, we're going to go to the next slide now, and we're going to take a look at the leak within the circuit. So again, this is waveform, and if you look at the volume waveform, you see this drop in volume, this little avalanche, and it's indicated here by the arrows pointing at this drop in volumes. When that happens, a situation like this not only has a leak, but also has a situation where you have an auto-cycling, auto-triggering, I should say. Now, the auto-triggering is very clearly identified on this slide, because if you're going to take a look at the simple digital rate, you're going to see that the rate this patient is on is 12 breaths per minute. Then when you're going to go on the left, if you look at the left column with the measured parameters, you're going to see that the rate is 31 breaths per minute. So why is the rate set at 12, but it's measuring 31? Because you have presence of leak. You have presence of leak causing auto-cycling because of the fluctuations in pressures and flows. And if you look at the pressure waveform, the very first pressure waveform, you will see no negative deflection. You will see no negative deflection on the pressure waveform. So what that really indicates is that the ventilator is firing a breath without being triggered. It's auto-cycling. It's auto-cycling as a result of a leak. Now we're going to go to the next slide. And if you're going to look at those loops, you can see on the right side there is a very nice drop in volume, and it's a reflection of how much the estimated leak is. And if you go to the left side, you can also see the drop in volume, where if you look at the loop on the left side, the loop does not come back to the baseline, does not come back to zero, and you can estimate how much the leak is as well on this slide. Now, this is plain waveform of pressure, flow, and volume. And again, if you look at this slide, you can see that the respiratory rate is set at 20, the measured rate is 25, but interestingly enough, there is not a single effort made by the patient on the pressure waveform. There is no negative deflection on the pressure waveform whatsoever. So you can see that this is leak initiated auto-triggering of the breath. Now we're going to go to the next slide, and the next slide is again this is a very interesting slide, because on the left side you have loops, so everybody can see what the leak looks like on loops, where the flow of gas is not coming back to the baseline. And if you look at the waveforms on the right side, we can take a look at the volume waveform and see this very significant drop indicated by a letter. You can see the arrow that has C on it. This very significant drop. And basically, from looking at this slide, I can tell you that this is very much of an indication that the patient has an air leak. And air leak can be coming from different sources. Air leak can be coming from an endotracheal or tracheal tube. Air leak can be coming from VP fistula. Air leak can be coming from a ventilator circuit, from chest tubes. You can have nasogastric tube. You can have NG tube or OJ tube slip in the airway. And if it slips in the airway, it will be pulling the gas from the lungs, creating this drop. in my practice, I've actually seen several instances for the last 25 years where the nasogastric tube slips into the trachea or gastric or OJ tube, and if it's connected on suction, you can see phenomena like this where you have a drop in volume and you think that something is really leaking. It's your chest tube affecting it, or your loose connection on the ventilator circuit, or your pivot balloon on your endotracheal tube, where in fact it might be an NG tube that happened to slip into the trachea, pulling the gas out. So that's potentially a very dangerous situation where if the tube is connected to feeding, that can literally kill the patient. Now we're going to go to the next slide, and next slide shows really very profound autocycling as a result of a leak. I want you to take a look at the pressure waveform. If you look at the patient, if you look at the pressure waveform, you do not see any negative deflection whatsoever. And then you see the breath starts way under the baseline. And then if you look at the volume waveform, you're going to see this very significant drop that occurs that indicates air leak. So something like this can really create extremely high level of autopeep and can really affect hemodynamic stability of the patient. You might be thinking that the patient is septic. You might be thinking that the patient needs more fluids or more pressors, and that's the reason why the patient's hemodynamic status is deteriorating. But something as simple as autocycling can really create a very dramatic hemodynamic instability. We're going to go to the next slide. And again, this is a situation with the autocycling, auto-triggering as a result of a leak. And this happened to be in pressure control. But again, it can be in any mode. It doesn't really have to be in volume or pressure. It doesn't really matter because leak and autocycling really reviews itself really the same way regardless of the mode of the ventilation. Now, this is the auto-triggering again as a result of a leak, and I think you've seen this slide before. I'm sorry, I think it's a duplicate slide, so we'll just fast forward. And I think this is finally a very peaceful slide where we have no autopeep presence, and if we're going to look at the end of the expiration, there is state of no flow. And the state of no flow indicates that there is most likely no autopeep present. And if you look at the volume waveform, you see that there is no really drop in the volume. So looking at this slide, it's pretty much machine-fired breath, and there is no leak really here, and there is no autocycling. Now we're going to go to the next slide, and the next slide is again auto-triggering. This is a little different. Auto-triggering as a result of a continuously pressure limited breath. I know that a lot of the times when we care for our patients, we can have a situation where patient has a mucus clog, or the tube slipped into the right mainstream bronchi, or we have an occlusion of some sort, or maybe the tidal volume is inappropriately high for that given patient, or maybe high pressure limit is set inappropriately. But regardless what the issue is, if the ventilator is attempting to deliver a certain volume and it cannot deliver it and it's being pressure limited, the ventilator will bounce back and try to deliver this volume again, and it's going to get in this tailspin of trying to deliver that volume autocycling. So you can have autocycling as a result of breath being pressure limited, and I'm sure that all of you have seen that happening. And if you look at this particular waveform, you see that there is no negative deflection in the pressure waveform, and at the same time, the ventilator is firing away. The ventilator is set to fire 15 times per minute, and if you look on the right side at the digital display, you see that it's really delivering 38 breaths per minute, and it's not as a result of patient effort, it's really as a result of pressure limited breath. But the breath is limited before it can deliver the volume it's targeting. Now, if you go to the next slide, we have a slide that reflects overdistension. I think it's a very important slide for our everyday life when we're managing a lot of our patients, and when we see something like that, it indicates to us that the lung is being overdistended, because you never really want to have if you look at the pressure waveform, on the pressure waveform you have beak that is very clearly present, and then if you look at the loops, you can look at the loops and see on the left side you have very clear shift to the right. Now, when you get a beak appearance on your flow volume loop like that, what it really indicates is that you're trying to deliver more volume and you're really now, with delivery of more volume, gaining more flow, As you deliver more flow, instead of a gain in volume, you get gain in pressure. And you never really want to have that, because at this point, you're really overdistending the lung and creating dynamic hyperinflation of the lung. We're going to advance to the next slide and look at the next slide. And this particular slide, again, on the left side, we have very poor compliance, and if you look at the loops, we have very clear shift to the right. And if you look at the pressure waveform, you see elevated peak pressure, obviously, on the pressure waveform. And then if you look at the slide on the right side of this slide, we see that now the compliance has improved, and the pressure came down on the pressure waveform. And of course, if you look at the loops, you're going to see that there is no longer a shift to the right. There is no more gain in pressure without gain in volume. So you can tell by just simply being able to compare waveforms and your loops to see that the compliance has improved. So we're going to advance to the next slide now. And then we look at the next slide. Next slide I thought was rather interesting, because if in the middle of a breath, if you look at the pressure waveform, if in the middle of a breath you get a dip like this, a lot of the times patient is flow starved and patient needs more adequate flow. You never really want patient dipping down like this and trying to grab more flow. So if something like this is happening, you might want to evaluate your patient and evaluate whether the pressure target or volume target is appropriate, whether the inspiratory time is too long or it needs to be shortened. But when something like this appears on a waveform, it typically indicates flow starvation. Now we're going to go to the next slide. And the next slide, this is a very interesting slide, I thought, because a lot of the times when we manage our patients, when we see a bump like this at the end of the breath, sometimes people say, well, what is the significance of this bump at the end of the breath? Well, in this particular slide, what it really indicates is the fact that the inspiratory time is too long. The inspiratory time is too long, and the patient is trying to terminate the breath by actively trying to exhale at the end of the breath. So in a case like this, the remedy would be, of course, to reevaluate patient pressure control target, and of course, most importantly, reevaluate inspiratory time, and most likely making it shorter to accommodate patient ability to exhale and go to the next breath. We're going to go to the next slide. Oops, I'm sorry, I think. Hold on a second, I'm sorry. Okay, we're going to go forward, I'm sorry. Let's see. Okay. I'm sorry, I just had to, I think I made some kind of a mistake here and I kind of fast forward and then had to go into rewind. Bronchodilator response is very nicely seen when you have ventilator graphics and you can analyze them. If you look at the peak expiratory flow rate, where the letter A is, it's decreased and expiratory flow returns to the baseline very slowly with the bronchoconstriction administration. Bronchodilator improves TFR and allows expiratory flow to return to the baseline within normal time. So, in other words, if you look at the left side, you see how prolonged that expiration is. You have an obstructive event. You have airway obstruction. Patient received the bronchodilator, and hopefully on the right side, if you look on a slide that's exhibited on the right side, the expiration is in a much more timely fashion. The patient was able to return to the baseline, and there is a good response to the bronchodilator. So I hope that for all of us folks that administer bronchodilation therapy on a daily basis, you see this every time you do it, and not just because if you administer a bronchodilator and the slide that appears on the right side looks exactly like the slide on the left side, the prolonged exhalation, it means that that bronchodilator really did not affect patient in any significant way. So what you really want to make sure is when you administer bronchodilator, when you analyze your graphics, you can look and see the differences in your pressure waveform that are much lower on the right side, obviously, because the peak pressure came down after the administration of bronchodilator. And then, of course, if you look at the expiratory side, you see how the flow is returned to the baseline in a much more expeditious way. Now we're going to go to the next slide. And this is another interesting slide that can really be, when you see something like that, it typically indicates either the patient needs to be suctioned and there are some secretions in the patient's airways, or there is a possibility of some water in the inspiratory and expiratory or inspiratory and expiratory line, because you're not really supposed to be seeing this artifact during the inspiratory and expiratory phase, and I think that in this particular slide there is water was really in the inspiratory and expiratory line. Now this is another ventilator, different ventilator, but the same situation. We have water in the inspiratory and expiratory line, and the remedy would be really to make sure that the water is drained, and if this would have been secretions, you would have, of course, suctioned your patient. Sometimes you can also have flappy airways, and it can create similar artifact, but with much less intensity than in this particular slide. Those are very frequent ones. But when you have flappy airways, typically it would be just a little less intense, but sometimes it's also possible to observe something similar to this slide. Now, this is a slide where I'm trying to demonstrate really a situation of severe autopeep. So if you look, you have two arrows pointing at the air trapping. On the flow waveform, you really were not able to exhale fully, and the patient was not able to exhale fully, and the breath is beginning under the baseline. So if you see something like that, it would be an indication of an autopeep, and of course the volume would drop and pressures would rise. Now, if you look a little further to the right, you see that towards the end, the last two breaths, I should say, the last three breaths, the very last breath has again developed some air trapping with the autopeep, but the two breaths before, the flow comes back to the baseline, and of course, because we eliminated that autopeep, the volumes are rising and the pressures are coming down. So that's what you pretty much want to see. You want to make sure that the flow is coming down to the state of no flow, coming down to the baseline. Now we're going to go to the next slide. And the next slide is very interesting because I was trying to simulate a situation that's typically observed over a period of time. Imagine that you're weaning your patient, you have your patient on CPAP with special support, the patient is doing really well, and there is a negative deflection on a pressure waveform where patient is triggering a ventilator, everything looks wonderful. And then over a period of time, the patient graduates to the point where the work of breathing is significantly increased, and that work of breathing is revealed by looking at those arrows, and you can see that the arrows are pointing to much deeper triggering by the patient than it was in the beginning of the slide. Because if you look at the beginning of the slide, the effort on the part of the patient was not so substantial. It was nice and comfortable, but then as the time progressed, that effort became much more aggressive, trying to trigger the ventilator because the patient is air-starved. And like I said before, you can develop autopep even in CPAP with pressure support, because if the patient is developing very aggressive inspiratory effort, and let's say patient has substantial COPD component, it can create dynamic hyperinflation of the lung, and you can really wind up with a lot of trapped gas, which is indicated by the presence of autopep. And if you look at the flow waveform where those two arrows are pointing, the patient is in CPAP with pressure support, triggering a breath, but now has to overcome the autopep that's present in order to open up the demand valve. Now we're going to go to the next slide. And the next slide is, again, this is a good slide. This is CPAP with pressure support. And this is what you really want to see. What you want to see is when you look at the flow waveform, if you look at the flow waveform, you see the expiration comes to the baseline, to zero, and there is state of no flow. So at least dynamically, when you analyze it, you can eyeball it and see that there is no obvious autopep present. Of course, if you want to do a full maneuver, you would want to do the full maneuver with the state of no flow and measure what the autopep is at the end of the expiration. Now we're going to go to the next slide. The next slide is talking about upper and lower inflection points. So the lower inflection point is a point that you want to set your PEEP at, typically where the lung opens up, and then you get to the upper inflection point, over which you really, everything over that point really will cause overdistension. So I always like to bring this very simple example of a balloon, of a water balloon, or I'm sorry, not water balloon, of a regular balloon that you're trying to blow up. The hardest part in terms of opening the lung up, imagine that you have a balloon that you're trying to open up. You're blowing into the balloon. The most difficult part is to get the balloon to open up. Once the balloon opens up, then you just blow into that balloon nicely, and then you get to the point where you're blowing into the balloon. The balloon is gaining pressure, but it's not gaining much in volume. So this is exactly what you want to avoid. So you really want to ventilate patients between lower inflection point and upper inflection point. So in order to establish lower inflection point, you want to have a patient that is not participating in breathing efforts, so you can do slow inflation of the lungs, so you can determine what is your lower and upper inflection point. Then you want to set your PEEP. You want to set your PEEP typically 2 to 3 centimeters above your lower inflection point, so you have an open lung. So you don't have to have cyclical opening and closing of the lung all the time, because if you're going to have cyclical opening and closing of the lung all the time, you can really cause ventilator-induced lung injury. And if you persist doing cyclical closing and opening of the lungs, it can cause inflammatory response, cytokines release, changes in your interleukin 6, 8, and 10, and this is exactly what you want to avoid. You want to ventilate lung in the most gentle way by keeping the lung open and not having cyclical openings and closing of the lung at every breath. And then, of course, you do not want to get to the point where you're blowing more air into the lungs and start getting...
Felix, I'm sorry to interrupt you, but we are losing your volume. Have you moved away from your microphone, or
no?
I can turn up your volume a little bit?
I can turn up the volume. I'm sorry. Can you hear me now? Is this better?
Not very well.
How about now? Is this better? Can you hear me better?
No, I haven't detected any change. Are you?
Let me see.
Now you seem to be getting a little bit louder. Can you
move
the microphone closer to your mouth?
Yeah, it's pretty close. Can you hear me now?
No.
No.
Can you turn up the volume on your microphone a little bit?
Right. I actually turned it to the maximum. Can you hear me now? Bill?
No.
Bill, can you hear me now?
No, we're losing it.
Huh.
No, not very clearly, but go ahead and try and finish your presentation. We'll just have to listen very carefully.
I'm sorry. I hope you can hear. I'm going to speak a little louder, okay? Can you hear me a little better now?
Great.
This is better?
Yes.
Okay, great.
Yes, go ahead.
Great. Okay. So, like I said, we typically would like to make sure that you ventilate patient between lower and upper inflection point without having cyclical opening and closing of the lungs and without over-distension of the lungs. If we're going to go to the next slide. Next slide is really just showing what happens if you want to take a look at what is your peak pressure. What's important to really realize is that the peak pressure shows several different components. You have your PIP, then when you're doing the inspiratory hold, when you're measuring your bladder pressures, it will reflect intrapulmonary pressures, hopefully to some degree, and your PEEP. So you can estimate your resistance and compliance, and in order to calculate resistance, of course, you're going to, in a simplistic way, you're going to do PIP minus your plateau pressures divided by flow. Now, I just wanted to talk for 1 second, if I can come back just to the previous slide, just for 1 more second and mention something. At the previous slide, I showed you the upper and lower inflection points. And of course, a lot of the times the remedy in order to keep the lung open is to increase level of PEEP to keep the lung open. But sometimes increasing level of PEEP beyond appropriate level that would be appropriate for a given patient will affect, of course, your plateau pressures, your mean airway pressures, and of course, at some point, in order for you to try to recruit certain regions of the lungs, just simply keep increasing PEEP might not necessarily be the answer, even though in a lot of instances it is. In a lot of instances, appropriate level of PEEP will do the trick, but there are going to be circumstances where you might want to consider alternate ventilatory strategies to try to recruit the lung, whether it's various types of high-frequency ventilation, whether it's prone positioning, whether it's administration of ECMO, but at some point there might be a circumstance where just simply increasing level of PEEP indefinitely will not necessarily be the answer, especially if your plateau pressures are going to be climbing above 30 centimeters of water pressure. And I just also wanted to measure something that I don't have a slide on, but I do want to mention that I think is really important, is if you're in business of managing a lot of ARDS patients, you might want to consider an important tool that I think is very helpful in management of ARDS patients is management of transpulmonary pressures, because management of transpulmonary pressures can really give you a good estimate of what your PEEP really is supposed to be, because you might have a very high level of PEEP and you might think that PEEP of 20 or 25 should do the trick, and this is just impossible. Why I'm not able to recruit that patient? But if the patient has compartment syndrome, and if the patient has high bladder pressures or abdominal pressures, you might actually, even this high level of PEEP that you set on the ventilator, you might still wind up with transpulmonary pressures that are a negative number. And you never really want to have a negative number in your transpulmonary pressures. You want to make sure that your transpulmonary pressures are between 0 and 5. Okay? And as you all know, transpulmonary pressure is measured by alveolar pressures minus intrapleural pressures. And in order to measure transpulmonary pressures, what typically would happen is one would drop an esophageal balloon, and it can be done. There is 2 different ventilators in the market, to the best of my knowledge, that are capable of measuring transpulmonary pressures, but you also can interface it externally with the with the cardiac monitor and trace it on it. But generally what you're going to do, you're dropping an esophageal balloon and you want to measure esophageal pressure, and then esophageal pressure would reflect your pleural pressures. Okay, and you will subtract, of course, pleural pressures from alveolar pressures and get your transpulmonary pressures. So like I said, typically you never want it to be a negative number, because if you have a negative number, you're really de-recruiting your patient at the end of the exhalation, and at the same time, if your transpulmonary pressures are greater than 5, you're really harming the lung, and you need to reevaluate your strategy on what volume you're targeting, what pressure you're targeting, and what PEEP you're targeting. All right. Now, let me just get back to where I was. I'm sorry. Let me get back to where I was. And this particular slide, I really wanted to indicate the significance of ventilatory scalars. You know, when we look at the graphics, some ventilators automatically set the scalars for us based on the patient breath, and we really don't have control over it. But there are ventilators out there that are capable of allowing you to manually set the scalars. So why is it so important? If you look at the at those 2 slides, actually came from the same ventilator, and the settings are exactly the same. But when you look at the volume waveform, on the left side where the letter A is, you see that the scalars are set to very small volumes. Very large volumes. So you do not see the leak that you really have on your volume waveform. But at the same time, if you're going to go to the right side of the slide, you're going to see that the scalar is really zoomed in, and you can see that there is about 50 cc's of gas that is being lost. So the way the scalars are zoomed in or out can play a difference in you being able to identify some very fine details, and one of them would be, in this particular example, would be the leak in the ventilator circuit. Because if you would look on the left, on the graphic on the left side, you don't really see any drop in volume. But then, of course, once you zoom in, you see that there's about 50 cc's that are being lost. So like I said, a lot of the ventilators nowadays do it automatically, but you do have those that allow you to do it manually. And so how you manually set the scalars can really have very profound effect on what you're really looking at, especially if you're dealing with the situation where you're trying to capture every little bit of volume that is affecting your minute volume. At this point, folks, I would like to thank everybody that participated in this webcast, and I would like to thank ARC for allowing me to conduct this webcast, and I'll gladly take some questions.
Felix, I want to thank you for presenting this wonderful information and all the examples that you provided. It was very interesting. We are just about out of time, however, so I would like you to go over to the discussion box there on the left, and if you would scroll up through that, you'll come to a couple of questions there at the end, and if you would like to address one or two of those questions, that would be fine. Thank you.
Sure. Thank you so much. Let me just look at some of the slides. Now, some of the slides, it's like, I'll give you an example, like some people are saying, is this sort of eye, or is this an 840 ventilator, or it doesn't really, folks, it really doesn't matter. I have, to tell you the truth, I have 11 different ventilators in my facility, and to my therapist, it doesn't really matter what ventilator you look at because the leak looks the same on the ventilator regardless, whether it's a Puritan Bennett ventilator, whether it's Hamilton G5, whether it's Draeger V500, it doesn't really make a difference what ventilator. Once you know what your graphics should look like, you should be able to identify auto-peep, you should be able to identify leak, you should be able to identify some general things that are everyday life. We can, of course, talk about some very advanced modalities that one can identify through graphics, but I would say that 90% of modalities that are utilized, or 80% of modalities that are utilized in most hospitals, are really very general, basic modalities, and I think that those examples, regardless of the ventilator, really pretty much come across in the same way. And I purposely got a lot of different slides from a lot of different ventilators because I didn't want people to feel that I'm biased towards one particular ventilator or another, because I'm not. And since I have 11 of them, I feel like the father of many children. I know who is good, bad, or ugly, but when it comes to graphics, they're all the same as far as I'm concerned.
Well, again, Felix, I want to thank you very much. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.